Scott Flinn and Greg Buchert, and we're going to finish up. Remember, the aspirational goal is 98th percentile, and to get more of the health plans in the state, or the related medical groups into that. And so, Blue Shield and then Health Net, we're going to talk about some of their strategies to achieve that. So the theme really is how do we get there from here? And Scott, background is at Arch for a number of years in San Diego, and brought in a vast experience there. There was a big help in launching the Right Care initiative in San Diego. So Scott, you can start off.
All right, thank you, Stephen. Afternoon, everyone. So we're the last thing between you and the awards ceremony and the reception, so we'll be accurate and brief. Right, Alan? Right. Can everyone believe what just happened? I mean, really? Has it been a historic time in America or what? I mean, can you believe the Cubs won the World Series? So, Bob, I wanted to thank you for your presentation today because I'm going to take this home to my kids. I'm telling them you need to stay in college, right? Don't smoke and don't get old. So, yeah, we'll go ahead for it. I'm here to talk to you today about the Blue Shield participation in the Right Care Initiative and what we're doing. We are here to provide care where there are family and friends, and a cost-affordable way. We wanted to have affordable health care for all Californians, and that's really why we're participating in this, as well as the DMHC, as Stephen alluded to, has asked us to really help to lead this program. We have historically have been in the middle of the pack when it comes to RCI metrics. You saw some of those earlier today of where we are. You had Kaiser at the 90th percentile, Sharp Health Plan around the 90th percentile on many things. And then there's the rest of us kind of middling around in there, and then 70th, 50th, et cetera. But that's not where we want to be, not where we want our members to be in terms of healthcare surrogates for showing how you're doing in terms of cardiovascular care. So we were tasked to go ahead and come up with a plan to reach the 90th percentile by 2018. Okay, so that's what we were tasked to do. And we developed that plan recently, and we started the implementation. And this is our report out of what we've done so far. Ultimately, our goal is to eliminate all preventable heart attacks, strokes for all Californians. And that's where we want to go, and that's why we're all here. So just show you where we've been. This is 2014 data. I didn't have access to the 2015. Obviously, you just showed it. A rival health plan and is in the orange dots on the top there, all 48 RCI metrics, Kaiser, of course. And you can see what the 90th percentile is, and the blue dots are Blue Shield. So we have some we're doing okay on, and some we're right in the middle. We're kind of middle. And that's not where we want to be or where we want our members to be as we move forward. So we developed a plan to help work with our partner provider organizations to reach that 90th percentile. And we started to implement that plan. We currently have 6 of our ACO partners that we're engaged with across the state with about 80,000 members. Try to get towards that plan, and that's just our start. We developed a best practices assessment for diabetes and hypertension, and that was the check sheet was based on the lessons we've learned from the Right Care Initiative here in LA and down in San Diego, and also that we've gleaned from other organizations. Some of you may be familiar with the AMGA Measure Up Pressure Now campaign, the New Together Goal campaign, Million Hearts, etc. So it was not just from Right Care, but there are many synergies, as you can imagine, when we developed our checklist to work with the groups. Based on that checklist, we're conducting gap analysis to see, here's what we think are the best things to help you move the needle, what are you doing now, and then what are the differences that you do. This is basic program management, right? And come up with an action plan based on that gap analysis, and then how can we help as Blue Shield to help you close those gaps and get to where you need to go for the 90th percentile. So what we're doing now, we're expanding our pharmacy programs to tap on what Rebecca was just talking about. Personal stories, back when I was at first at Arch Health Partners, I was not much of a believer as a pharmacist on the care team. I wasn't quite sure what they were doing in my primary care space. And there may be other physicians who felt that way also, still are. But we had a Coumadin clinic that was there, anticoagulation clinic. And I was familiar with it from my time in the Navy also, and the pharmacists did it very, very well. Okay, well, they did well at Arch too, but they weren't pharmacists. They were actually nurses who were doing it at the time. And they did a pretty good job. But then we brought a pharmacist in to run it, and he took it to the next level. Really expanded it, their attention to detail, the way they follow up with the patients, the knowledge they had was just really amazing. So when we were participating in the Right Care Initiative, UBP down in San Diego, we said, this pharmacist on care team thing may really work well. So we incorporated it into our hypertension program, and we found an amazing result that happened. First, we got a clinical champion, worked with a pharmacist who was the head of the internal medicine department, and his hypertension control numbers went over the 80th percentile in about 2 months. Now, not that doctors are competitive or anything, but the other docs around said, hey, because we were publicly posting results and showing what people were. And they're going, hey, how's he doing that? Oh, you know, he's working with the pharmacist. Well, why is he working? Why can't I do that? Well, you can. You just need to sign this clinical practice agreement, and off you go. And so that's how we got it going. One of our cardiologists was at 32% when we started. He got up over 60% in a couple months. Yeah, well, you know, they're newfangled drugs, everything else they got going, paying attention to the basic blocking and tackling. I know we like to think of this as just a surrogate for this, but really, controlling hypertension is a basic thing, and we don't do it well. When you're at the 90th percentile, and you're hitting 80% control, and everyone else is below you, there's a lot of work to do there. We are implementing quality goals in our ACO contracts. So we're putting our money where we think the outcome should be. So they're actually having quality goals in our ACO contracts and implementing them. Nothing revolutionary about that, but actually getting the groups to agree to that is good work that we're doing to help them get there. And we are attending university best practices in all 3 locations. Happy to be there, help to garner all those best practices and share them amongst the groups as we go out and continue our work there. So the best practices, most of you are familiar with these. This is part of the list. It's not all of it. There's about 17 things we've identified, both for hypertension and diabetes, that really work. But here's some of the highlights. Again, implementing a care team with a pharmacist and a CDE really seems to move the needle in terms of getting hypertension control and diabetes control, and continuously measuring that success. Having that registry, having that basic infrastructure there is critical. And again, public reporting inside the provider organization, letting the docs know where their compatriots are in an unblinded way. We didn't start that way in my last group I was at, but when you show them, hey, you know, you're not as good as Dr. Smith over here. After they get over that initial, the data is wrong, this is wrong, that's wrong, right? Get through that denial phase. They go ahead and step up a little, and it's amazing what you can do when you get folks motivated that way. This is something we got from Kaiser. What's the thing we focused on first? Why we focused on hypertension? Because if you look at that right there, you can. It's an estimated to get a 17% reduction in major adverse cardiac events, deaths, within 2 years if you treat hypertension. Now these are the high-risk patients, those over 55 with high blood pressure. Okay, so why do you go after hypertension first? It gives you the most bang for the buck, and you get the ROI on that first. What's most important longitudinally? Probably cholesterol, but short-term, it seems to be the hypertension. So what we've learned so far is that many provider organizations have different efforts. They're kind of scattered. People are doing some things very well. Some folks are doing all the things very well. But it is very variable as you go out there and talk to the different groups. The Right Care Initiative helps to synergize those efforts with all those other programs that are listed up there that you're all pretty familiar with. And we think it's an excellent vehicle to help get that information that's out there and gives them a framework for how to work on this. Again, hypertension control does seem to have the biggest near-term effect, and that's where we focused on that first. And we're going next to diabetes. Where we want to go, we're going to continue to enlist our provider organizations in this effort. We back into the number of how many of our members we're going to have to affect to get to that 90th percentile. And so we have a target on how many groups we have to involve and how many patients we have to involve. And that's a lot of work to do over the next 3 years, but we're going to do it. We're going to continue to refine our approach based on our experience in the best practices and other venues, and we're going to get to the 90th percentile on RCI metrics. We want to eliminate those preventable strokes and heart attacks. That's why we're all here. And with that, I do want to show you one more thing. If you go on Google, it gives you the little thing for the day, and we're going to do a Google search. And today, it's Frederick Banting. He won the Nobel Prize in Medicine for being the first doctor to give insulin to a patient. How appropriate.
Greg Buchert, and Greg is the CMO of HealthNet. He's also the president and CEO of the California Health and Wellness Plan as well. Greg.
Thank you, Steve. Actually, one point of clarification, I'm no longer the CEO of California Health and Wellness, so I am just the CMO of HealthNet. That's enough to keep me busy right now. Well, thank you, and again, it's dangerous to be between you and a reception, so, and having had it anyway. Speed it up, so I'll try to be brief and all. Cut past some of the things we've talked about already.
You have 20 minutes.
Okay, thank you.
And then we'll go to 10 minutes of Q&A before the session.
Okay. So this morning we heard about how the RightCare initiative is a public-private partnership. And actually, I think I can share with you that it truly is this great public-private partnership. And some of it is a little bit manipulated, if you will, that like Blue Shield, we also are required to participate more aggressively in the RightCare initiative. And the bar has been set high for HealthNet. And so by having this collaboration between the MHC, the RightCare initiative, and HealthNet, we can impact the health of about 3 million Californians. And if we do a great job, we will definitely have a healthier state. So, since we're a number of months behind Blue Shield as far as the expectations and our requirements of what we need to do to reach that 90th percentile, and striving for that. But I'd like to just kind of lay in the groundwork for, really this is prefacing what's going to happen over the next couple of years as we come back and hopefully talk about a lot of the results. So HealthNet is operated in multiple states and with multiple lines of business, has a behavioral health company. And then here's comes Centene, which has operated plans in multiple states and has a portfolio of multiple specialty companies. And Centene established a profile with establishing California Health and Wellness about a mile down the road. And then Centene acquired HealthNet, which finally went down in about March of 2016. And so, okay, there we go. So, everybody would probably ask, who in the world is Centene? And so, it's the, just a little bit about that because it does make a difference as far as how we're going to be moving forward. And this is, you see that our purpose statement for being around is transforming the health of the community one person at a time. And it's more than just words on a page. I can tell you that in my interview with the CEO for Centene, he said, Greg, we don't take care of lives. We don't take care of members. We take care of individuals who live in families, who live in communities. And if we don't recognize that and don't acknowledge that and don't intervene appropriately, we're not going to make a difference. And so you really do see this community orientation of Centene and how they do things. And then there's this whole concept of better health outcomes at lower costs. So it's not a matter of doing things necessarily cheaper, but we really don't want to have cost-quality trade-offs in what we do. The other thing is that it's not some big national company. The fact that they brand every company and every health plan they have in the state shows that they believe local presence, local accountability is extremely important. And so what we do in California is for California. Centene has an integrated approach where they're looking at the physical health, the behavioral health, and again, pharmacy services, other ancillary services. And so they do a lot of the conventional things that most health plans do, but by virtue of the fact that it has this portfolio of specialty companies, as a CEO, I wasn't contracting with an external pharmacy benefit manager, an external dental company, an external vision company. Those are all sister and brethren companies. So it's a lot easier to have that internal accountability and internal data sharing. So what's the California landscape look like now? Right now, we are HealthNet. And Health Net, it's, is composed of what it's been there, including MHN, the behavioral health company, which you'll hear through some rebranding is now involved People Care. We serve about 3 million members, both Medi-Cal, which includes California Health and Wellness, our dual eligibles, our Medicare members, and about 850,000 commercial members. And so the reason I bring this up is you'll see that there's a lot of different activities that have happened over the period of time, and it's easier to focus, on some of the commercial members because of the dramatically higher cost, Medicare members because of their increased infirmity. But here we are, we have 2 million Medi-Cal members, and so as we're looking at reaching the 90th percentile, it really has to be for all members across the state. The other thing is in terms of the structure. There really is a sort of a three-way structure between what we can do as a health plan, and we've been talking a lot about the various medical groups, and so we have the capitated medical groups, and we still have some fee-for-service providers. An interesting challenge is for a health plan because the fee-for-service providers are submitting claims, and so all of a sudden the data is really good. The capitated medical groups, we're relying on them to submit encounters. The data is not always so good, and so it's a lot easier to count on our fee-for-service members or those issues where activities happen in capitated medical groups that we still have financial risk in. Briefly, here's the combination of California Health and Wellness on the white and Health Net on the left. So currently in Medi-Cal, we cover 31 counties in the state. On the commercial side, we cover actually all the state because the PPO product is available in all 58 counties, but it gives you an idea about the breadth. And Medicare, we're across the state. And dual eligibles, we're in 2 of the CalMed Connect counties. So what's been happening up to this point? And so as a baseline of where we're coming from, I just want to show you a little bit of Health Net has a long history of providing a lot of services. And as you look at them, I'm not going to go through every one, but these are activities that have been going on for well over a decade. And you'll see that there's been mostly a focus on member-facing activities. So here's Health Net that has the largest, it probably has the largest collection of medical groups we're contracted with and capitated delegated arrangements. We've been focusing primarily on mostly our members. And you'll see that as we move on, we've got California Health and Wellness, which also has had primarily member-focused activities. And since they just started in November of 2013, the list isn't quite as long, but again, it's been a lot of focus on the members themselves. So, we can go through a couple of the, there's a number of studies, but like many of you heard, we had an activity for the instituting and focusing on compliance with some of the cardiac protective bundles. And again, through pharmacy intervention, again, the pharmacist, kudos to you, thank you. We were able to increase compliance. But again, it was a Medicare program, Medicare-facing program. It was a team-based approach, and again, the evidence of the same things you've heard throughout the day, that it's not just one component, but it's multiple components in order to achieve results. So, if you look objectively, and I'd urge you to take a look at the green bar in the middle, which is the 2016 reporting year rate, and then the purple, which is the 50th percentile for national. And here we are challenged to get to the 90th percentile. So you can see whether it be commercial, Medi-Cal, or Medicare, we're pretty much at the 50th percentile for high blood pressure. We look at controlling blood pressure in diabetic patients, again, about the 50th percentile. So we've got a way to go. Hemoglobin A1C testing, we've got a long way to go because you can see that, especially in commercial and Medi-Cal, which is about 2.8 million of our members, we're not 50th percentile yet. And so from a baseline perspective, it's going to be a heavy lift. If we for those diabetics, we're, measuring hemoglobin A1Cs, generally we're doing a little bit better. So this is our baseline we're starting from. So what's next? There's a number of organizational changes that we've engaged in. First off is that we've had episodic participation in the Right Care initiative, both primarily here in Sacramento and down in Los Angeles. At this point now, we have medical directors assigned to attend, all three settings. And first, I've been to Sacramento and Los Angeles. I'm looking forward to go to San Diego and have a few of those craft beers. So those meetings are much more interesting. At least more.
They don't serve them in the
Because it wasn't
It's changed since I left.
We have bi-weekly meetings with all of our medical directors, and we discuss what the medical directors have heard at the Right Care Initiative meetings. And one of the things that's been interesting is to have the medical directors say after these kind of discussions, like Dr. Clark was talking about the doctors getting energized, they're saying, we're talking about clinical topics. It's not just, utilization and cost and contracting and things like that. I feel like a doctor again. And then so it's, again, thank you. We're discussing things with our contracted medical groups, making sure that they know that they're invited to the University of Best Practices, because it's important to get engagement from our partners with the groups that often are the closer to our members than we are to plan. We're focusing more on our highest risk members, and so it's a more tailored effort in terms of some of our outreach to our members. And we are slowly transitioning from some challenging data collection to more having an enterprise data warehouse and having some better tools to analyze the data with. Again, we're looking at doing another initiative that we're starting right now. A couple of docs came back from the San Diego meeting, and they were so energized about what they heard about Kaiser and all the things we've heard about, great things going on in San Diego. So we've got to do this, but so what we are looking at now is, you saw the same things as far as the statistics, but importantly, we're focusing on our Medi-Cal patients now. We're focusing on FQHC patients. And so it's a group that, remember earlier we did a cardiac protective study in our Medicare patients, but now we're doing it for the Medi-Cal patients, much larger, and a group that we're not, have not necessarily been as engaged with. And as more members are getting into FQHCs, as we have and hopefully we'll continue to have Medicaid expansion populations getting engaged with the FQHCs. It's a group that we're going to be spending progressively more time with. I did like the switch on one of the slides, how they went from, Lovastatin to just lipid-lowering drugs. So you can still keep the ALL acronym. I like that. We're working with our behavioral health company, MHN or BPC, as part of keeping track of all those three-letter acronyms, to help ensure compliance, and they are training some of our health coaches and working with our disease management company to focus more on these members. And then, it's going to be, are we making a difference? And so that whole evaluation phase is going to be very important for us. Right now, we still have multiple licensed companies, and so California Health and Wellness is still operating somewhat independently, and they're, we're doing a lot of interventions along with the, focusing on our members, both the low-risk members and our high-risk members, because we think it's important to outreach aggressively to those. And I looked at this today, I said, this is kind of like that menu at the car wash, and all of a sudden it's like, they get the first floor, then it's like shiny wheels and, air fresheners. But you can see that we spend a lot more time with, again, getting the behavioral health providers in there and getting more aggressive involvement in case management. Also, California Health and Wellness, we're doing some things with regard to practice coaches. So here we are, where HealthNet has been primarily focused on working with our medical groups. California Health and Wellness is primarily fee-for-service arrangements, and so we've been doing some work with at the individual practice level, both the providers and the practice managers. An important thing is, here's not all the information on the page, but it is over on the right-hand side, is that we're defining our measures, we're identifying what our baseline goals are, and we have timelines for evaluating, are we making a difference? And so it's not just throwing a lot of spaghetti at the wall and hoping something sticks, but actually, measuring to see if it does stick and how well. And as far as additional activities coming up, we do have more provider engagement activities than we've had in the past. And so, as I mentioned earlier, a lot of them have been member-focused, member-facing, but doing a little more provider-focused activities. And so they include tip sheets for providers, some more information about both heart disease as well as stroke information. Again, bringing in the behavioral health group, again, we're focusing on the kids that are on antipsychotics, and are they leaning towards they have risk for metabolic syndrome. And so it's that potential collateral damage of what our interventions are, and are we creating problems in addition to solving problems. HealthNet has traditionally had outsourced its case management, disease management, and with the evolution to Centene, we're actually going to be insourcing all those activities, and so we'll have a lot more visibility on what's going on and how to measure, and be able to influence those discussions back and forth with our case management staff and our disease management staff. And because we rely so heavily on our capitated delegated groups, we've really stepped up the comprehensive overview that we're looking at our medical groups to make sure that we're looking at their quality, their operations, their quality of HEDIS and CAPS, their operations, and their cost efficiency and cost effectiveness. And so we're able to focus, really kind of break the groups down into those that are performing really well that we need to support, those that are might need a little bit of help and augmentation, and those that are performing very poorly, we're evaluating a relationship with them to say, do we need them for access, and so do we need to put a lot of time and effort into those groups, or should we say, maybe step more ways, because we want our members going to high-performing groups and ones that are producing the kind of results that are going to get us to that 90th percentile. And so it's an important way for us to evaluate our partners. So one of the challenges will be is to say, are we successful? So we've built tools that, and this is solely just a snapshot, but you can see that we'll be able to break down our evaluation, looking at the various diseases and those individuals with comorbidities with the disease we're focused on. And we'll be able to break it down by our line of business, by the various products, would be HMO, PPO, EPO, the networks that people are in, and even things where they on exchange or off exchange, and we cover California. And so we can slice and dice our data so we can really drill down to say, where are those areas, that same concept of hotspotting of, who's not performing well and where do we need to focus our efforts, and so we can tailor our interventions much more aggressively. At this point, at first blush, there's a quick view of our members, that 17% of all of our HealthNet members, remember we do have a lot of children, have one of the four diseases that we're focusing on with regard to associated with right care initiative. You can see the variations between 72% of our Medicare members have these diseases and 12% of our Medi-Cal members. We know that 70% of our diabetic members have one of the other conditions, and so there's a twofer if we can make a difference in those individuals. And from a cost perspective, you see that 60% of total claims paid, and this is not including capitated payments, are for members that are in one of these four categories. So not only is there a high prevalence of disease that we need to focus on, but also the high cost associated with it. And I was looking at it, so if we can drive down cost, it means that there's more money to do good things elsewhere. And so, we need to build bigger